Hi everyone, welcome to our talk on understanding dementia, a patient's guide. We've got an exciting topic and an exciting talk for you, so I hope that you appreciate it and that you get some good information out of this. So first of all, about us, we're Naples Concierge Health. We have 3 physicians in our practice. We focus on providing truly excellent primary care that covers a lot of different scopes that we have listed here. If you're looking for care in the Naples area, please feel free to reach out to us. I'm Dr. Jonathan Marsh, and we also have Dr. Linda Lucombe and Dr. Sultana Kulieva in our practice. So today we're going to talk about dementia. So we'll talk about an introduction, we'll talk about the different types of dementia, then we'll get into some topics you might not consider. We'll talk about how do we measure dementia. We'll talk about treatment options, including experimental treatment options. We'll talk about some coping strategies, and then finally some planning strategies that you might want to consider. So I hope that by the end of this, you have a good idea not only of the clinical interesting parts of dementia, but also how you might use some of this information to help you with any health issues you or any of your family members or loved ones may be struggling with. So first of all, let's define dementia, let's go over some statistics, and let's talk about some risk factors. So, dementia is a collective term for anything affecting cognitive decline. So it is things that are not reversible. So it's not infections, it's not a neurologic condition like NPH or normal pressure hydrocephalus that might be treatable. It's not a clinical condition like encephalitis that might reverse. If we're talking about dementia, we're talking about something that is not an acute issue, but a chronic issue by definition. Now, your physician should, before deciding that you have dementia, rule out potential causes of cognitive decline besides dementia. So typically, symptoms might be personality changes, memory loss, confusion, difficulty with language and speech. Sometimes changes in personality can be early signs of dementia as well. So some statistics. So the lifetime prevalence, so one person's odds of having some sort of memory decline dementia issue is 40%, which is pretty high. It's a very expensive problem. So healthcare costs exceed $305 billion in the United States. It's projected to exceed $1 trillion by 2050 because of the aging population here. That only covers the dollars and cents expense. It doesn't talk about the loss of value by family members providing care for people with dementia. That's not included in these numbers. This is the direct expense. It also doesn't take into account the personal costs of dementia. Of course, for the patient, it can be a major issue. It can lead to loss of dignity. For the families, it can require a lot of time and effort. It can be a financial drain. Sometimes people end up isolated, and ultimately it can lead to major health issues and ultimately death. So what are some risk factors for dementia? Of course, advancing age is the #1 risk factor. The older you are, the more likely you are to get some sort of diagnosis of dementia. Family history, if you have a family history of dementia, there are some genetic variants. There's also genes heavily associated with Alzheimer's, so that should certainly be taken into account. There are some risk factors that are controllable. So hearing loss, treating hearing loss aggressively can help prevent dementia. Avoiding isolation, having social connectedness is very important for maintaining our mental faculties. And then maintaining our chronic health issues, just like anything else, they do affect your risk of getting dementia later in life. So what are the most common types of dementia? Generally speaking, we look at 4 common types: Alzheimer's, vascular dementia, Lewy body dementia, and frontotemporal dementia. So just to speak in generalities, Alzheimer's is the most common type. It affects 45% of people. Vascular dementia is next. It affects 15% of people. Lewy body disease is next. It affects 5% of people. And frontotemporal dementia affects 1% of people. Now you'll notice these don't add up to 100%, and that's because a large portion of dementia cases are not diagnosed definitively into one of these categories. That having been said, with newer technologies and blood work coming out, I would expect that more people will have a diagnosis of a specific type of dementia instead of dementia not otherwise specified in the future. So let's talk about Alzheimer's disease. So Alzheimer's, as we said, is the most common type of dementia. It primarily affects memory, thinking, and behavior. It gets worse with age. The risk factors are genetics, and the genetics of Alzheimer's require special consideration, which we'll talk about a little bit later. Physiologically, it is from the buildup of tau and amyloid proteins. So tau protein builds up inside the nerve cells, and amyloid builds up in between the nerve cells, preventing them from communicating correctly and operating correctly. It does tend to have an older age of onset. It says greater than 65, and then as you age, the risk gets higher and higher. So a 90-year-old has 5 times the risk of somebody who's 60, for example. We do have some treatments right now that can help the brain sort of function better when we are affected by Alzheimer's. There are some newer treatments that help prevent the progression of Alzheimer's, and we'll discuss those soon. There's not currently a cure, however. Vascular dementia. Vascular dementia is when parts of your brain don't get enough blood flow and they stop working correctly for that reason. A stroke is an example of vascular dementia, but it's not only strokes. Sometimes when you have high blood pressure, high cholesterol, you get microvascular disease, so vessels that are too small to be resolved down to one area, but you can have thousands of these tiny losses of blood flow lead up to dementia. It can occur in a stepwise fashion if you do have multiple strokes, but it can also occur more slowly and insidiously. Typical age of onset, again, is after 65. The risk factors for vascular dementia are the same as the risk factors for stroke and heart attack. So it's high cholesterol, lack of activity, being obese, diabetes, these types of things. Lewy body disease. So Lewy body disease is caused by an abnormal protein buildup, just like Alzheimer's is, except it's a different protein. It's alpha-synuclein instead of amyloid and tau. So Lewy body disease has a distinctive presentation often. It usually presents with visual hallucinations, and it'll be sometimes very strange things like little green men running around or people feeling like there's people in their room at night. Sometimes those are presentations of Lewy body disease. Parkinson's could be considered a subclass of Lewy body disease that affects more motor function rather than the presentation I was just talking about. So I'm sure people have been saying, where's Parkinson's in here? It's considered a subset of Lewy body disease. Typical age of onset is a little bit younger than Alzheimer's and vascular dementia, but it's still usually after 50. It can vary. And again, family history of Parkinson's disease, age is a risk factor. There's some genetic risk factors as well, but not as clearly defined as for Alzheimer's. So frontotemporal dementia, again, it's a protein buildup, but it's different ones. It's tau and TDP-43. Frequently, frontotemporal patients' initial symptoms are a disinhibition, a change in their personality, and sometimes we see older people and their family says, boy, they're getting older and they're getting wild and we can't control them anymore. That can be an early sign of frontotemporal dementia. So getting that diagnosed can really help if you're having interfamily issues. It might be something to consider. Typical age of onset, a little bit younger than Alzheimer's, between 40 and 65, more in that Lewy body sort of area than in the Alzheimer's and vascular dementia area. Again, there's some certain genetic mutations associated with this, but it's not as prevalent or as major an issue as it is with Alzheimer's, but genetic testing, if you have a strong family history of this, can provide some information. So here's a breakdown of the different types. Again, Alzheimer's, older, more purely memory. Vascular, older, can present in a variety of different ways. It can be stepwise, or it can be more of an insidious presentation. Frontotemporal, more with personality changes and Lewy body, potentially visual changes and hallucinations, also sometimes more of a Parkinsonian presentation. So let's talk about how you might measure dementia. So generally speaking, we look at functionally, how are you doing? There are some other tests to look for dementia and quantify things, but usually we want to know how's the brain actually operating. So a lot of primary care offices will do a mini mental status exam, which is the one where you like draw a clock and they ask you to remember a few things and ask you to repeat some sentences backwards. And that's a good test. It's a good screening test. It does tend to catch things a little bit later than we might hope. Some people like to go psychometric testing yearly, in particular if they have a high family risk. We're fortunate in Naples, we have a facility, Aqualane, that does clinical trials in neurologic medications, and they'll do one for you yearly. That's a bit more in depth than the mini mental status exam. But if you're concerned, you can do in-depth psychometric testing periodically to see if there are any changes, or you could ask for this for a family member. So other objective findings, imaging. So the gold standard is a PET CT of the brain. So PET means that they look at where glucose is being used in the brain. So you see the metabolic activity in different areas of the brain. And one thing about this is that Alzheimer's tends to have a different pattern than vascular and Lewy body and frontotemporal. So this can help differentiate between different diagnoses, and it can also give you an idea of how advanced the disease is. So if you get sent to a neurologist, for example, with a questionable diagnosis of dementia, often they will do one of these PET scans. Just out this year, available through Quest and LabCorp, are the PTAW 181 test and amyloid tests. These are peripheral blood tests to look for some of the abnormal proteins that we know are associated with Alzheimer's. So I've had a lot of interest in this in our clinic, and they can be interesting tests to follow. The one caveat is that they are new, so no one really has a ton of experience following these closely. These are only for Alzheimer's. There are other similar tests pending for frontotemporal and Lewy body disease, but they are not widely available through the typical labs that we use yet. So let's talk about treatment a little bit. So we'll talk about, in general, how might we try and prevent ourselves from getting dementia if we are at high risk for whatever reason. Then we'll talk about the different medications that are available, going all the way into medications that may be in the experimental stages. So first of all, I'm high risk for dementia, let's say, and how am I going to help myself not get it or get it later? Physical activity is a huge thing. Even if you start it later in life, there are studies that aerobic activity in particular stimulates the hippocampus, which is the part of the brain that's associated with forming new memories. So it's never too late, and getting out and getting active. And for this in particular disease, doing aerobic activity is helpful and important. Maintaining a healthy weight, avoiding the chronic medical issues of diabetes, obesity, metabolic dysfunction are all really important. Mental activity, meaning staying connected socially, doing puzzles. They have even brain training games out that they claim they've studied and improve your mental acuity, but continuing to remain engaged is really important for maintaining your brain function. Another thing is treating hearing loss really aggressively. If you lose the input to your brain of your ears, or you would argue your vision as well, getting those improved will help keep your brain stimulated and everything moving along nicely and help prevent degeneration in the future. And again, it's worth re-mentioning treating your medical issues, keeping your blood pressure, cholesterol, all those things under control, not only help with the vascular dementia, but several of the other dementias as well. So what are some treatment options? So right now, as far as Alzheimer's goes, we have cholinesterase inhibitors and we have memantine. And these medications, what they do is change the balance of chemicals in your brain to help stimulate function and better memory. They are temporary bandages. They don't work for everybody. Some people have a good response, in particular if they have mild cognitive impairment. Some people, the response is not as good, and it tends to be individualized. These are not medications that are actually changing the underlying process of the dementia. It's not improving blood flow to the brain, and it's not changing proteins being laid down in any way that's going to affect the course of the diseases. but they can help. Other ways to help besides the medications that we currently have approved are to have a plan in place. So we're calling that coping strategies. So if you have an established routine, or if they're your loved one, you get an established routine. People with memory issues do really well when they're doing the same thing every day, especially if you can start it early in their life and not when they're older and already having significant struggles. That can help everything go much more smoothly. You can use memory aids, meaning having, notes around the house and visual prompts for what needs to be done next. Staying socially engaged and participating in activities, staying active helps people, again, just sort of flow through their day and not run into issues where they need to rely on their memory that may not be there and be as strong as it used to be. Some coping strategies for families. So this is where I want to talk about communicating and day-to-day with people who maybe have mild cognitive impairment, maybe have advanced even a little bit past that. So these are just some tricks and tips from people who've been there before. So one thing is that people who have a poor memory a lot of times have difficulty following the chain of conversation, the thought thread, is in particular if it's long and complex. And
are you recording?
Yeah.
We're supposed to meet at 10:30 whenever you're ready.
We'll do it in like 30 minutes, okay?
Okay. Just check.
Coping strategies for families. So here we're going to talk about how to work with people who have memory issues and may be struggling. So this is to help sort of the day go smoother and not end up with conflicts and issues that are unnecessary. So one is that people who have memory issues have a hard time following complex conversations. So your tone and your facial expressions when communicating with them is extremely important. If you're acting frustrated, they're going to mirror off of that and they're going to feel frustrated, and then you're going to have difficulty communicating. Another part of that is to keep your communication simple. Another part of that is to keep your topics on things you know they can handle. Talking about their younger life, things 10, 20 years ago that they still have easy recall of, is going to go a lot more smoothly than trying to ask them about what they're planning for later today or what they did yesterday, because they don't remember those things. And if you can imagine sitting and being grilled by somebody on material that you don't have, a test that you didn't study for, that would be very frustrating for you. So asking people with cognitive impairment about things that they can't possibly know the answer to is very frustrating for them as well. Another part of this and an offshoot of that is to not contradict patients who have memory issues. If they say that they went to the grocery store yesterday and they didn't, there's really no sense in correcting them. So there's also no sense in trying to convince them of something that's coming up or going to change, especially if they've decided that that's not the case. Unfortunately, they're probably not going to remember it, and you're going to have frustrated them and upset them for no reason. So keep the topics on things that they can understand and that they can follow. Stay around familiar topics. Don't spend your time arguing with them, because they're going to respond to that tone and they're going to get upset. So just do everything you can to sort of smooth out their days for them. So on top of coping treatments, let's talk about the new medications that are coming out. So right now, there are monoclonal antibodies too that have been released that are for treatment, and these help remove and clean up the protein tangles in the brains of patients with Alzheimer's disease specifically. This is supposed to slow the actual progression of the disease. Currently, there are two that are approved, Leqembi and Kisunla. These both are approved for mild cognitive impairment. There are some studies ongoing on using them to prevent the development of cognitive impairment. Right now, that's limited to people with rare familial causes of Alzheimer's, but we would hope to see this be generalized out to the more common ApoE3, E4 genetic variant cause of Alzheimer's. And that's currently being studied, so keep your eyes open. Hopefully in the next few years, we'll have some more information about that. Lokimbi is a 2-week infusion, and Kisunla is a 4-week infusion. Right now, they're contraindicated in certain patients. This is something you would want to talk to a neurologist about to see if you are a candidate. There are some experimental treatments in development. One is another experimental monoclonal antibody. Another is a translational inhibitor of neurotoxic aggregating proteins. These are still in trials, but again, if you are 40 or 50 or 60 and you're worried about developing this disease in your 70s or 80s, there are things in the pipeline. And then the final thing that's being studied is semaglutide. Semaglutide is Ozempic or Wegovy, and these medications seem to have some delaying effect on the development of dementia. It's unclear if there is something specific with receptors in the brain, or it's just a matter of reducing body weight and therefore inflammation, and then that shows improvement. But there are trials for that, and they're actually doing that here in Naples at Aqualane Center. So let's talk about planning strategies. So there's a lot of difficult decisions that need to be made. We'll talk about these. We'll also talk about, should you consider genetic testing, how you might screen. We'll talk about considerations for support in the future you might need to make, and then also considerations for financial and potentially legal planning. So if you are high risk for dementia for whatever reason, or you're worried about dementia, you have some difficult decisions that you're facing. One is driving. How do you handle driving? You don't want to wait to decide about driving until someone has been driving dangerously for the last 5 or 10 years. Ideally, if you know that you're high risk for dementia, you can talk to your family and make a plan about how you would want this to be handled so that they don't have to do it when you are sort of not able to make your own decisions anymore. What are your medical goals, your long-term care goals going to be? Again, if you are high risk or you have a family member who's high risk, to have this conversation ahead of time is really invaluable. You don't want to end up institutionalized with like a feeding tube if that's not your wish, but that is how things tend to go unless you have a conversation with your family and friends and let them know what you would like to do. One thing that can help with these decisions is to undergo genetic testing. If you have a very strong history, you can undergo genetic testing to look for rare causes of these diseases. Most commonly, you're looking at the ApoE gene. So there is a ApoE gene that can be either a 3 or 4 variant. And if you have one copy of ApoE4, then you are 3 times as likely to get a Alzheimer's type dementia in your elder age. If you have 2 copies of the ApoE4 gene, you are 8 times as likely to get this as the general population. So if you have 2 copies of ApoE4, as you progress into your 80s and 90s, you become practically guaranteed to get these, to get memory impairment. So if you know that's going to happen, then you know it's more important to address these questions and issues than it is for a person in the general population. So deciding to undergo genetic testing is a personal decision for sure, but it is something to consider, and it can help color all of these other conversations and let you know how urgent and important they are. Should you know that you're high risk or you're concerned that you're high risk, you can undergo periodic screening to try and catch diseases, to try and catch memory issues before they've progressed. This can be really important for financial and legal planning. If at some point you are incapacitated and people are going back and pointing to, oh, when was this document signed? Was it appropriate or not? If you're able to have the testing, this was done, this, confirm that you were of sound mind at the time that this was done, that can be important. And it can also be important in terms of figuring out if you are not of sound mind and letting family and friends know that where it is now, it's locked in, help avoid being taken advantage of should you, unfortunately, end up in a position where you're dependent on someone else. Another question you need to ask yourself, and you need to have these conversations, is support. How would you like your support to look should you have really poor memory? So some people feel very strongly that they do not want other people in their house. Some people feel very strongly that they do not want to go to a memory care facility. Which one are you? Talk to your family about it. Is it something in between? And then this plays into financial planning in terms of what will you be able to do at that time. And to go ahead and have those conversations now so that everybody is on the same page is super important. Having a medical provider that you're working with consistently over the years who knows you well can be really helpful for detecting some of these early personality changes or memory changes and alerting the family who may not live in the same area as the patient. That can be really helpful as well. One tip with support is to always choose a support agency that works with a lot of people with memory issues, because interacting with people with memory issues is something that can be learned and can really impact the quality of life of the person. So, for example, like we said before, not arguing with them, choosing topics that they are comfortable discussing can really improve someone's quality of life, staying busy, as opposed to ending up in sort of a neglectful situation. So just some ideas, just some things so you know that they're available. One is respite care. Respite care is basically a medical hotel, if you will, where if someone needs some medical care, they're dependent on their spouse or their family, but that person needs a break for whatever reason, you can go to respite care just for a few days, pay for it like a hotel, have someone who knows a lot about memory care help give you a break. There's also day camps that are available that keep people active with puzzles and interaction and communication so that a caregiver can get out of the house for a little while. Of course, a lot of support is provided by family. I would just, ask everyone to, if they have someone in their family who has dementia, to check on that person's spouse or children and offer to help and make sure that they're not getting overwhelmed. Because it can be a lot. And the caregivers need care just like the person who is sick needs care. One thing people don't want to talk about, but financial planning. Sometimes in families, finances are a closely guarded secret, but if you know that you're high risk for memory issues, you really need to think about who in your family is going to help you make decisions. If you don't have any close family, you need to think about how you're going to handle your affairs, getting, legal expertise involved early, getting financial expertise involved early, having your wishes written down is really important. And then also, what is your plan plays a lot into this. 24-hour care at home, if that is your plan, is quite expensive. And having an idea of where you would want to go, when you would want to go to that place ahead of time can make sure that you end up somewhere where you want to be instead of somewhere someone else chooses. So I hope that this was helpful. I hope it wasn't too scary. We did have, it's a tough topic. We wanted to make sure that we tackled everything, even if it's not something we really want to dwell on. I hope it motivates some people to be proactive about their care. I hope that you found it informational, and I hope that it is something that you will share with others. Again, we're Naples Concierge Health. If you want to reach out to us in Naples, Florida, we are at naplesconciergehealth.com. We are located downtown. That's our phone number. If you need anything, if you have any further questions, please don't hesitate to reach out to us and ask. Thanks.